So today's session comes to us from our partners at Highmark Health and Allegheny Health Network. AHN has been a CTSI partner since 2021, and together we've accomplished so many things. For example, jointly, we've designed and implemented a clinical research course for students at 4 local Penn State campuses. Also, together we have developed a collaborative and co-sponsored research pilot funding program for Highmark, AHN, and Penn State researchers looking to advance health. Sorry. For more information on our CTSI partnerships, please visit our website, and I'll put the link right to the partnership information again in our chat. So today's presentation showcases results from an ongoing research collaboration between Penn State, College of Medicine, and Highmark Health. It's titled Trends and Cost of Telehealth Use Among Mental Health Patients, a claims-based COVID-era analysis. And it's going to be presented by Pooh Bai, a Doctor of Public Health candidate, and Dr. Emily Brignone, the Director of Social Determinants of Health Analytics at Highmark Health. Pooh Bai's research focuses on the cost and utilization of telehealth for mental health care. She has collaborated with Highmark Health's Social Determinants of Health, SDOH, analytics team over 2 summers to conduct real-world claims data analysis. Her work bridges academic rigor with applied health data science, emphasizing scalable insights that support underserved populations and improve care across COVID-19 timeframes. Emily has worked for over 7 years in roles spanning research, advanced analytics, and health equity. Since August of 23, she has led enterprise-wide initiatives using payer data to inform population health strategy and integrate social determinants of health into care delivery. Previously, she managed the SDOH analytics team and served as a senior research data scientist, building on her training as a postdoctoral fellow in health services research at the VA Pittsburgh Healthcare System. Dr. Brignone's work, published in JAMA Network Open, BMJ Open, and Preventative Medicine, focuses on diseases of despair, health disparities, and the integration of SDOH into payer-provider systems. And she is recognized as both a thought leader and a mentor in applying advanced analytics to improve health outcomes. So with that introduction, I'll turn it over to our presenters so that they can take it away.
Thank you so much, Jessica. Good afternoon, everyone. Thank you for joining us in Pooh Bai. Let's invite my advisor and collaborator on this study, Dr. Emily Brignone from Highmark Health. Yes, Jessica did a great intro already, so we'll just dive in. As Jessica said, this study has evolved to be part of my IDR under the mentorship of my mentor, Dr. Lee Wan. Also, thanks CTSI for invitation today. Emily and I will be sharing our findings on how telemental health use evolved through the pandemic and into the post-COVID era. So, what is telehealth? Essentially, you can get medical services at a place where you find it comfortable talking to a doctor over real-time video, audio without showing up in the office. So when we look at the patterns across the pandemic, we're not just looking at the technology, we're looking at the shift in the access. The pandemic wasn't one single moment. Telehealth use unfolded in 4 distinct phases. In the pre-period, the telehealth was really limited, especially for behavioral health. And when the COVID landed, telehealth exploded after the national emergency declaration in March 2020. By the later phase, vaccine effectiveness brought the crisis to the stability. And after the federal public health emergency ended in March 2023, we entered the post-COVID period, the first time telehealth existed without emergency waivers, but still with broad coverage. And I'd like to mention that one reason this study is so important is what happened recently in Medicare policy. With the government shutdown on October 1st, CMS put a temporary hold on claims processing. At that time, several pandemic-era behavioral health telehealth flexibility expired or became more restricted. However, telemental health has not completely disappeared, but just the access was no longer as broad as before. Um, and that's why our study is so timely. Our post-COVID data set ends in February 2025, capturing the last stable period of telemental health use before these new conditions went into effect. For mental health, telehealth wasn't just a convenience. During the pandemic, it became the backbone of outpatient care. Many patients were able to maintain therapy for the first time because transportation, stigma, scheduling barriers were removed at that time. But here's the problem. Most published studies stopped at 2021 or early 2022. We know that almost nothing about post-COVID part, who use it, what drives it, and how the patterns differ across the populations. Our study questions actually uncover what happens now and were post public health emergency and some flexibilities have sunset. This is the first study we know of that uses 2023 to 2025 real world claims to answer this. Speaking of the data, Highmark's commercial claims covers Pennsylvania, West Virginia, Delaware, and surrounding regions. This data set is extremely rich. It includes enrollment files, medical and pharmacy claims, provider information, and something most commercial data sets don't have, the social needs assessment, which Emily will talk about it in detail soon. And importantly, Highmark data has the short lag time. Most claims appears within 30 to 90 days, allowing us to study post-COVID use in near real time. That's why our findings fill such an important gap. So the cohort consists of adults with depression and anxiety, two of the most common behavioral health disorders. For the post-COVID period, which is our main analytical window, we require 12 months of continuous enrollment prior to May 2023. This let us accurately calculate baseline comorbidity and ensures complete captures of utilization. And the final post-COVID analytic sample is quite large. It's around like 197 192 adults. Now, let's take a look at how telehealth actually changed from our data. So we have two charts on the top for overall telehealth use and two on the bottom specifically for telemental health. On the left side, we're looking at member level percentages, and on the right side, we're looking at the claim level percentages. What's really important here is to notice how the lines change from the peak period, the acute COVID, into the post-COVID era. For overall telehealth on top, you can see a steep drop off once we move past that peak. But when you look at the bottom two other um, charts, which are for mental health specifically, the decline is much more gentle. Um, so telemental health usage stays relatively stable even after the overall telehealth usage drops. The takeaway is while general usage fell sharply after the peak, mental health telehealth remained quite steady. That tells us that people kept relying on virtual mental health services even as other types of telehealth tapered off. So, who used telehealth the most? When we compare users and non-users, we found that young adults are far more likely to use telehealth, especially those between 30 to 44. Women accounts for nearly three-quarters of telehealth users. Urban residents use telehealth much more than rural residents. And among patients who were assessed, those with the social determinants of health needs are almost twice as likely to use telehealth. So the typical telehealth user look like younger, female, urban, and often with identified social needs. That's just based on the statistical analysis. And speaking of who use telehealth for mental health, we have the binary parts results showing that the strongest predictor is age. The odds of telehealth visit being mental health related drop sharply as age increases. Men have lower odds, rural residents have lower odds, senior plans have lower odds as well, like compared to other coverage plans. And we also have the intensity part of tele mental health use. Uh, Again, age shows a steeper gradient. Younger adults return for repeated telemental health visits, whereas older adults do not. Men and rural adults also show lower use intensity. Plan type matters. Individual use, like individually insured adults have higher repeated teleuse. So at this point, we've looked at overall and mental health specific telehealth use, but one of the strengths of our data set is that we can look at the social needs. I'm going to hand it over to Dr. Emily Brignone to walk us through the SDOH findings.
Thank you. So I'm just going to spend a little bit of time sort of digging into what SDOH are, why it's important to health services and clinical translational research, and what we're starting to see in Poo's data for her IDR. So you've probably heard this stat before. Social determinants of health are estimated to account for between 50 and 80% of variation in health outcomes. An example of this is people in the richest zip codes on average live for 15 years longer than people in the poorest zip codes. And SDOH can contribute to health in a variety of ways. Often it leads to the development of chronic disease or the exacerbation of existing chronic disease. It's linked to mental health issues. It's people with SDOH needs are more likely to miss their appointments or put off preventive care for a variety of reasons. Poor treatment adherence, including drug adherence, much higher rates of maternal and infant health complications, and there's sort of a emphasis on acute care when we need to shift it to preventive. So often because of that delayed preventive care, people will end up in the emergency room or even being admitted because a problem that would have been treatable in primary care sort of got out of hand. So there's a real interest in understanding how people with social needs can benefit from telehealth because, there's a lot of ways that it might directly address some of their barriers, including transportation to and from visits. With a lot of people, there's childcare obligations and they can't pay for childcare, can't find childcare. I think that statistic that we saw a minute ago about the percent of users that are female compared to male is probably at least in part related to that. There's in rural areas or in some urban areas, there might be sort of like medical resource deserts where it's hard to get in with someone close by. So having telehealth opens up the pool of available providers. It can also improve mental health access, which is important for this group because even though we see higher risk for certain mental health conditions, that doesn't necessarily correspond to higher rates of utilization. So they're not necessarily getting treatment for conditions that are diagnosed. And then, of course, telehealth provides more flexible hours, which can be helpful for people with shift work or erratic hours or whatever it may be. And then just a note that hybrid is probably optimal where, there's places where telehealth is the right thing, but can't replace in-person care. So to get it a little bit more into the Highmark data and Highmark's approach to SDOH. So Highmark was kind of early to the party on SDOH integration at the payer and provider level. In 2019, we stood up our enterprise social determinants of health team, and they quickly got to work developing this assessment, which is still used today. And these questions are drawn from other validated instruments and are meant to sort of cover the range of domains that we're trying to get a feel for among our members. You can jump to the next slide. So since that assessment went live in 2020, we've captured a little over 3.5 million assessments, and that covers about 1.5 million individuals. So a lot of people who've been assessed multiple times over years, which allows them to understand sort of chronicity and, if we close the gap, is the gap staying closed, or is this more of an episodic need? And these assessments are recorded in a lot of different places because we're really trying to catch folks where we can, so that there isn't this big bias and like people who maybe have like reduced access to their doctor's office, we could maybe get them through a phone call with case management or an email link or through the online portal where they log in to see their health insurance information. And because of that, constant increase in the places where this assessment is available, the volume has really increased year over year. And then you can see the all-time rates of SDOH needs. This is at the assessment level. So the most commonly reported need is social connections. So there's questions about feeling left out, lacking companionship, or feeling isolated. We actually did a study. It was funded by that joint Highmark AHN CTSI grant on social connections and cardiovascular disease, and that just got published a couple of months ago. Health literacy is also common and more common among older adults. Financial resource strain pops up often and is obviously very related to a lot of these other categories. Transportation, although it has like a low percentage, tends to be like really tightly linked to a lot of problems. So even though it doesn't affect as many people who've taken the assessment, it's like a really good indicator for us. So we use these data in a lot of different ways. Obviously, like direct patient care and case management. So we try to make those assessment results visible to clinicians at the point of care so that they kind of understand the context for the person that they're working with and can ask questions, follow up on previous responses like, hey, last time you were here, you told us this, is that still an issue for you? And really help like build that personal relationship. If there is an assessment that's positive, it triggers an alert to our social workers, and they have access to this resource and referral platform called, it's called Find Help, but it's white labeled as the community support platform at Highmark. And then, of course, following up to make sure that when we identified a need, we actually did offer assistance and that people got what they needed. And then on the research and analytics side, we also develop predictive models that they're lookalike models. So based on what the data that we have about SDOH in our whole population, we sort of pick up on characteristics that indicate risk by domain. And we currently have models estimating risk for social connections, housing, and food insecurity, and they're surprisingly accurate. So it's exciting to see those evolve. And then, of course, like we're doing here with POO's research, really trying to build out the evidence base around SDOH and kind of get under the hood on why it is that it has such a outsized effect in health outcomes and health utilization. And so tying it to things like telehealth can help us understand potential opportunities to close the gaps that we find. And so this is data from the IDR. We looked at the odds of using telehealth and of using telemental health. This is like any versus none as a function of SDOH needs by domain. So people who reported that they had a transportation barrier had 90% higher odds of using telehealth than those who reported that they didn't have that barrier. The effect on telemental health is still pretty large at 1.47. And you kind of see for food insecurity, financial resource strain, and housing instability, it's like hanging around that 50% higher range, which is, I think, consistent with what we expected. And in a way, feels a little bit promising because it's, showing us that these services that didn't used to be accessible in this way are helping vulnerable people get care. So building out on this will include, who aren't we reaching? We saw that it was less commonly used among rural populations. So like, what are the reasons for that? Maybe there's an opportunity to do some qualitative work in that area. But based on the data that we're seeing in the post-COVID era, it does seem like folks with social needs are more likely to use these services. So I think that's the last one. I'm going to hand it back to Ramona.
Thank you, Emily. So stepping back from the individual findings, the bigger picture is really clear. Telemental health is no longer a temporary response to COVID. It's part of the mental health infrastructure now, and we can see from Emily's introduction how social determinants of health can be contributable to understand such problems like telemental health. It fundamentally changed who can access care. The telemental health changes the patterns of use, especially how younger urban and social vulnerable groups engage with services. And it changed the cost trajectories, which we haven't touched upon in this presentation yet, but it's going to be part of our IDR. I'd like to also mention that this study also surfaced several important analytics and operational challenges. Thank you so much, Emily, for always being supportive. First, working inside the Google Cloud platform, which is also a new thing for Highmark folks. Rewriting legacy R code into cloud optimized functions, managing compute costs, and handling extremely large tables. That was a learning curve in itself. And second, despite millions of SDOH assessments, 82.5% of our analytic population had no SDOH assessment at all. This isn't just a limitation, it's a signal that it means many patients most at risk for inequitable access are also the ones we know the least about. And to now, that's gonna wrap up our presentation today, but Emily has been working in the area for years and I've been doing this study for almost 3 years. So we're happy to answer any questions you have. And thank you so much for listening.
Thank you both so much for a wonderful presentation. So we're going to open it up to the group now. If anybody has any questions, feel free to type it in the chat. You can unmute and ask your question that way as well. But if anyone has any questions, Emily and Pooh are here to answer those for us. And everyone's usually shy with a question, so I'll start with my question first, and I'll get the ball rolling. So, Pooh, when you were showing the stats of who is using the telehealth. One of the categories was rural users. And here in our CTSI, that's our focus is rural health. And I thought telemental health would be way more popular among rural users. What are some of the barriers, do you think, that are keeping folks that are living in rural areas from using that telehealth service?
That's a great question. Like, I remember when I initially started the literature review of this whole telehealth study, what I read is rural areas are like where the policies like, because they have the accessibility issue, they have barriers sometimes related to transportation. But I think the one important part is, first of all, the internet connections, because like telehealth, most of the telehealth version is video, and you need to have the internet to connect to the video. Phone calls is like less of the trend as time goes by. And also some other components such as health literacy in the rural areas in some places can also be the issue of not like spontaneously seeking for help, especially when it comes to the telemental health that we're talking about.
Yeah, thank you so much. Yeah, I could see the transportation. That was the one thing that I wrote down, was that transportation I could see as being a barrier. But definitely like internet connection, sure, when you're out in the rural areas, if there's no tower close by, what are you gonna do? Yeah. Thanks, Pooh. Anybody else have any questions? Go ahead, Felicia.
So I live in a very rural area. I moved from like New York City to like rural Pennsylvania. And one of the things I've noticed here is that we don't have the manpower to provide mental health services. The waiting lists are like over a year long. And I had to be very persistent to get my own therapist, and I use telehealth. How can we increase accessibility to mental health professionals outside of our general area to circumvent waiting lists, because it's hard to stay persistent for a year. And if you need help now and you've taken the leap to ask now, to wait a month is maybe okay, but to wait a year, like your problem may not even be there anymore, may have escalated so far beyond what it originally was. So, how can we intervene to help people access the services that are not available locally?
Thank you. I think that's a great question for Emily to answer. And part of the answer is the Find Help platform they've been working on.
Yeah, so I think we do have to look to more like digital solutions because it's hard to, move bodies into areas when we already have shortages, even in urban areas. So, Highmark recently launched a program as part of their insurance products. It's called Spring Health, and it's like a digital mental health solution where you can choose providers. It's like a hub, sort of like some of the ones that you see operating outside of insurance. And we use predictive analytics to send out marketing materials to people who are living in rural areas and we know struggle with some of these things. So we're trying to raise that awareness of these resources. And then, like Pooh said, there is another resource and referral platform that um, is primarily for social needs, but because that's often so tied up in mental health, people will get referred through that as well. And sometimes those are digitally available.
Thank you so much. It looks like we have some questions in the chat. First question is from Nicole. For the SDOH patient assessments, do you get positive feedback from patients about incorporating these assessments in their care?
Great question. And it's a mix. Some people are especially early on, they're like, why are you asking me this? This is my doctor's office. Why do you care about these things? And so it did take a little bit of socialization. And there is a script that sort of goes at the beginning. It's optional, but a lot of times they'll just sort of read, we do this for these reasons. It's how we help find people who need help. And these are relevant to your health. I can't remember exactly what it looks like, but sort of setting the stage by explaining to the patient who may not know about the link between social barriers and health, like this is why we're asking, this is how we use this information. But at the same time, we also get plenty of people who are like, I'm so glad that you're asking this. This is amazing. There's so many people that need help. And even the people who report needs and get help are like, I had no idea that this was available through my health insurance. Like everyone hates their health insurance. So it's nice when we can do something unexpected.
Based on that, Emily, is there like a charge for using that service if you're a Highmark customer?
Like the Spring Health.
Mm-hmm.
So it's like based on the insurance product, but
Okay.
most of the time it will be sort of like separate, much like therapy will be, so that it doesn't cost the same as like a specialist visit. And the mental health is through digital is often more affordable. So if someone was going to choose in person, they might end up paying a little bit more.
So we have another question. Thanks for the presentation. How do you define telemental health? Did you get a chance to look at the originating sites, like where patients were located during the visits?
That's a great question, and that's related to our study methodology. And the logic is one good thing I like about Highmark health insurance data is that it's pretty comprehensive. So we define the telemental health in two parts. It's going to be the telehealth claims, and it's going to be for mental health specifically. So we have separate codes for telehealth and mental health services. For telehealth, we have like place of services and some other procedure codes, and for the mental health codes, we have the Milliman code, which is a roll-up high level of code that covers including diagnosis procedures that can be used to identify this claim as for mental health specifically. And the other part is, did you get a chance to look at the originating side? Can you talk a bit about what do you mean by originating site? Do you mean like the zip code or?
Thank you for the answer. The originating site I mean is so when accessing telehealth services, patients can be located at home. They can also be at doctor's office. Did you got a chance to look at these?
Um, that's a great question. Again, like the way we identify telehealth services is from like the health insurance claims. And with that claims, that's already like collected. And the way we use to identify telehealth is from the code that's categorized as the telehealth visits. I'm not sure if the raw data includes something like that.
Did you have place of service?
Yes, we do.
Does it reflect something? Because I would think it would be interesting because initially patients were asked, before COVID, patients were asked to be at the rural clinic to access telehealth. I mean, for general, like more Medicare, Medicaid. I'm not sure about the high mark. And during the COVID, CMS, they took away that requirement so patients can access telehealth when they're at home. I'm just curious if you got a chance to look at that, like provide more accessible care, even without transportation at all.
I think we might be able to dig into that a little bit with the data that we have. We haven't yet, so that's a good idea. When we're identifying a visit as telehealth, we're looking at criteria across a few different fields, including place of service, because there is one that basically says telehealth. But by combining place of service with like maybe the CPT code or the procedure code modifier that indicates telehealth, we might be able to get that information about different places of service that are considered telehealth.
Thank you. Thank you. Yeah. Yeah.
Thank you.
Does anyone else have a question or a comment? Anything they'd like to know more about? And it's okay if we don't. That just means that the presentation gave us all of the information that we were looking for. So thank you both so much. Our next TSS will be on December 10th at noon. So I'm going to put the information about that in our chat, and you can use the CTSI newsletter to find. Oh, Felicia made a comment that she has lots of thoughts circling. So I'm sure, if you do have additional questions, Felicia, if you want to send them in to me, I can get them to our presenters to get an answer for you. Or if you have thoughts or anything that you wanted to talk about, definitely send them to me. I'll put my email in the chat as well so that you know how to contact us.
This is very important to me because like I said, live in a rural area and I want to do telehealth here from my home. So I'm like highly interested in what you guys got going on. So I'm really excited for the recording.
That's wonderful. And the recording, like I said, we'll send it out to everyone that was registered for the presentation today, but we also store all of the recordings from all of our TSS presentations on our CTSI YouTube channel. So you can always go out there and take a look and see what's out there if you need more information about anything. So with that, we'll end our call for today, give you back a few minutes of your time, especially that it's the lunch hour. Go maybe get a snack before you finish your workday today. Thank you so much for joining us, and thank you to our presenters.